It's my privilege to present the work that I've been doing for the past 8.5 years in focal shockwave therapy. I have no conflict of interest to disclose, but I would like to acknowledge the manifold people who are actually involved in helping us develop this, the numerous referrals that we have got from everyone, and the fact that I get challenged every time to treat conditions which are not within the indications that we will explain later on. So it has been a very nice journey, although at times we've had to stretch our imagination a little bit. But there are important principles to actually note as we go through this lecture. The objectives of this study is to identify the new innovative indications of focal shockwave in sports, to explore best practice possibilities in the application of focal shockwave. Do note that there are different ways of using the devices. You would need to make sure that you know your device properly so that you can provide the proper treatment and the best possible results with whatever modality that you have, and to evaluate evidence of efficacy and safety of application of focal shockwave in the newer indications. And this is a picture of the device that we have. The main device is at the bottom picture, and the applicator is at the top picture. There are 3 different applicators, of which they are having different function. There are gaps in evidence. First of all, there's a lack of evidence in efficacy and safety of focal shockwave therapy in less common indications, many of which are only level 4 or level 5, and some are only case series or case studies. And do note that in previous studies, they always use different ways of diagnosis and different technologies, different dosage, and this makes it difficult to actually interpret the results for your patients using your device. And there's also limited studies regarding outcomes, especially in athletes and especially in the Middle East. Well, in this statement, in a recent study, they mentioned that there's wide clinical diversity and varying treatment protocols, meaning that we do not know whether some of these trials tested with subtherapeutic doses, usually underestimating the potential benefits. So again, what protocols you use will determine what kind of outcome which you will have. So many of the previous studies do not use the appropriate level of energy required. What is shockwave? Here, this is my definition. It is a non-invasive treatment modality using acoustic waves, basically sound waves that can carry energy, allowing it to propagate through medium or tissue to be targeted towards and focus to affect a particular effect at distant anatomical region. And you can see in the graph here, there will be a sudden change in pressure in nanoseconds, and that would result in a pulse of energy being propagated through the tissue. And there are 2 types. The ones which is focused, where the wave is actually focused externally outside the applicator, and another one which is radial, where the wave is actually propagated and in diverging manner. Historical background is important to note that it has been used in the past in wars, okay, by the Navy, okay, and this has been done to actually bomb and kill sailors in the submarines using depth charges. And in the late 1970s, the terminology of focal shockwave has been coined. In the 1980s, they have been used in kidney stones, to break it down, and this included also urethric stones. And following in 1986, they have been used in fracture, non-union, delayed union, stress fractures, and they have been found to be up to 88% effective in treating these fractures. And this has been done primarily in Austria, where it's first line in non-union fracture treatment. And in 1990s, they have been used in tendinosis, plantar fasciitis, and shoulder calcific tendinosis, where there is very good evidence, level 1 evidence that it actually works. 2004, it has been used in skin for non-healing wounds, diabetic ulcers, decubitus ulcers, and even burns. In 2010 onwards, it has been used in urology or sexual medicine, especially erectile dysfunction, chronic pelvic pain, low back pain, and also spasticity, post-stroke, motor neuron disease, and cerebral palsy. And there are many more indications where they need more evidence. And over here you can see the old device, which is huge and cumbersome, being trialed for over here. And over here you can see the small fragments of the bone after they break the calcification. And this is how powerful some of the older machines are. But the newer machines are less powerful, but not less effective for calcific tendinopathy. What are the different types of focal shockwave? Obviously, you do know that the radial shockwave is freely available. It's available in many physiotherapy clinics. And it is very useful. And there is also the focal shockwave. What are the differences? There are 3 different types of focal shockwave: the electrohydraulic, the electromagnetic, and piezoelectric. And for the radial shockwave, some of people call it radial pulse wave because they may not consider it as a shockwave, but we will call it radial shockwave for now. And do note that the focal area is smaller because it's called focus, between 2 to 8 millimeters for the focal, but it is much wider in the radial device. As a result, it is less painful. The tissue penetration is much deeper, and the range is much wider. So you can actually go from superficial to deep for the focal device, depending on the applicators you use. And the cost obviously is anything probably 10 times, if not 6 times higher than a radial device. The energy flux density is more versatile, anything from low energy level to a high energy level. And you do not need to use any anesthetic in the newer devices, unlike the previous devices where it can be very painful, especially for fractures in long bones and in the hip. They will need to use general anesthesia. But in the smaller devices that we have in the clinic, no anesthesia is required. And we will discuss a little bit more about why not having anesthesia is important over the next slides. And when you have an effective device like this, we note that you do not need to shock every week. You do not need to give many shocks. You only need to give 1 to 3 treatments for focal shockwave. And for radial shockwave, anything from 3 to 5 at least. But if you know how to use it properly, and if you shock adequately, you can actually reduce the number of shocks and the number of episodes of treatment. It is actually quite portable. There is a bag that you can tug it along. The German Olympic team actually has a focal shockwave that they bring along whenever they go for competition. How does it work? Well, we do have animal studies, we do have human trials. It does work through mechanotransduction. It's a nice term where everybody says mechanotransduction. Yeah, but what is it actually? So you do have cell signaling pathways and histochemistry to actually show some of that. And these are the 2 things that we are looking for when we are using focal shockwave: the tissue regenerative options and the pain management. So how can you do it? In tendons, it has been shown to help with tenocyte proliferation and extracellular matrix regeneration, and also collagen synthesis. And also, it has been shown to modulate VEGF angiogenesis and osteogenesis. It has also been shown to work with ischemic tissue, and all this will help to promote the healing of the tissue with increased vascularization, and also improve bone formation. And over here you can see that it actually stimulates osteoblastic activity. It stimulates tissue growth factor synthesis in human osteoblasts. So this is one of the mechanisms that it actually works with fracture healing. In cartilage, It has been shown to work on tissue chondroprotective effect in rat knees. And it has also been shown in human studies where it has been shown to be chondroprotective. If you look at the hip necrosis, it has been suggested to modulate nitric oxide levels and promote osteogenesis and angiogenesis. Unfortunately, we do not have a device which is strong enough to actually penetrate into the hip to actually evaluate that. You will need a bigger machine for that. And in rats, they have been shown to improve the peripheral nerve regeneration. So the effect is on the Schwann cell also. Should I say, fortunately, we are not treating nerve injuries, but this is an area that we may explore in future with low energy levels. So when we look at pain management, it's a very important thing. So over here, they talk about hyperstimulation analgesia, destruction of amyelinated fibers, nerve fibers, and suppression of neurotransmitter substance P and calcitonin gene-related peptide. So these are some of the mechanisms where it actually works. So it's not hocus pocus. They are animal studies, they are human studies. And we are actually doing work with patients, and they do work, as you will see in the next slides. And over here, we are talking about the indications. There are three different types. The common indications, the empirically tested indications, and the last one is the expert indications. So over here, if you look at the tendinopathies, the chronic tendinopathies which respond very well with level 1 evidence, these are the ones: calcific tendinopathy of the shoulder, the tennis elbow, the greater trochanteric pain syndrome, the patellar tendinopathy and quadriceps tendinopathy, Achilles tendinopathy, and plantar fasciitis. If you look at the bone pathologies, it is used very much so with the bigger machines to treat delayed bone healing or non-union fractures and stress fractures. They are also used for avascular necrosis and osteochondritis dissecans, but they are not so common. That's why I put it in brown. Obviously, skin pathologies, we do not treat them over here, but you cannot actually use it for wounds. We've had a few cases for painful scars and wounds which are not healing very well. That's about it that we have. That's because we have a very good infection control team, and the surgeons are very particular about their surgeries. Now, if you look at the common empirically tested clinical indications, you have tendinopathies also, and rotator cuff tendinopathy without calcification. We'll see in the next few slides that they don't respond so well, but we still do them from time to time. The golfer's elbow or medial epicondylitis, adductor tendinopathy syndrome. Again, we have the groin pain study over here, so we try to avoid the groin pain. And with the groin pain study that we have in Aspetar, we know that everybody gets better with exercise. So we do only keep this for people who still have pain after the rehab, or just to push them a little bit. And the next three, which are in brown, are less common indications, fairly painful indications that I try to avoid, but I still do them from time to time. And they do work also with low energy level. The other bone pathologies are bone marrow edema. You know that bone marrow edema can be found many times with osteoarthritis in the joints and with focal cartilage defects. This is something that we will talk more later on. Osteoarthritis disease, we only keep it for adults who have had previous osteoarthritis which become symptomatic later on. We do not tend to want to treat younger athletes, although it is treated in Germany. Tibial stress syndrome, Dr. Toll mentioned that. Marty Moen has done systematic reviews on that. It seemed to work quite well. However, we are not too keen on doing that because I believe that you do need to have proper training methods and proper gait retraining, especially for athletes who are just going into sports. So this is something which is more related to load, which can actually solve the core issue. When you look at muscle pathologies, yes, you can treat myofascial syndrome, especially the postural pain syndrome in the shoulder. And we do treat the IT band, trochanteric pain syndrome also. They work really well. Dr. Elizabeth can actually send some of her patients with the forearm myofascial pain, and they do work quite well. But this has to go with rehab. And muscle sprain without discontinuity is something that is done, not so common. Obviously, cellulites, unfortunately, I'm not able to help. Musculoskeletal pathologies, which are there, osteoarthritis, we are starting to treat more of this. In the past, we have only kept this for athletes with early osteoarthritis, but nowadays we are actually exploring to provide more to sedentary or active public patients. Dupuytren's disease, De Quervain's disease, and trigger finger. I leave it for the surgeon. The surgeon does a really good job. The corticosteroid injection works really well. So I may not shock them because, again, you have to be fairly gentle with this. Plantar fibromatosis, we are doing it since the beginning of what we were doing here. So it works really well. The other neurological pathologies like spasticity, polyneuropathy, and carpal tunnel syndrome, they do work, but it is out of scope. We are not going there yet. Urologic pathologies, it is out of scope, and others like lymphedema, they do work, but with a different way of application. So these are the expert indications. Contraindications, if you use the lower energy level, there are much fewer contraindications. So what we always say, use the lower possible effective therapeutic energy level. Don't go immediately high. And the contraindications are malignant tumor and fetus in the treatment area. So almost never. If you use the high energy focused wave, you need to avoid the lung, any malignant tumor, the epiphyseal plate, the growth plates, and the brain or spine, and severe coagulopathy and fetus in the treatment area. And over here, we do need to mention that local anesthetic analgesics are not required for the medium level devices that we have because we need to pinpoint exactly what are the structures which are causing pain and then focus on these areas. If you actually wipe out the pain, we don't know where to treat. So NSAIDs and COX-2 antagonists may interfere with the localization of a painful area. Do note that a washout duration of at least 1 month is required if you do give oral or IM corticosteroid injections. So PRP is fine. Now, I would like to suggest best practice protocols for focused shockwave. And this is very important to make sure that you get the best possible results, less side effects or adverse events. Okay. First of all, you need to confirm your diagnosis with clinical skills and imaging. Okay. Sometimes a little bit of a difference in the diagnosis, whether it's a tear, whether it's a tendinosis, whether it's a tendinitis, will change how you will actually treat the patient. So we will mention more about that over the next few slides. And the duration of symptoms, whether it's acute or chronic. We tend not to like to treat acute patients because they will need more treatments and they'll be very painful, and sometimes you can have a flare-up. So anything above 6 weeks is good. Trial of conservative treatment, we always say you keep the best for last. You don't always use the heaviest, the most invasive method. Always have physical therapy. And I always give my patients a home-based exercises if they don't get physiotherapy over here, or at least they get referred to our outpatient physiotherapist who is perfect. And do note that we also use it occasionally when they have a failure of analgesics and failure of injection therapy, be it hyaluronic acid or platelet-rich plasma. And always use lifestyle measures. If your patients are overweight, do consider referring them to the nutritionist. Identify the goals of treatment. You must know why you are using shockwave. You don't use shockwave because everything else has failed and then you need to send, or because the patient is insisting on shockwave. Do note that every applicator, every energy level can do different things. So if you are considering that, that might actually work for your patient, whether it's tissue healing, pain relief, and removal of calcification, stimulation of bone formation, and improvement of range of motion. So there's a whole lot that you can do if used appropriately. And you must be patient. On the first day, the patient may have so much pain that you may not be able to shock hard, even though the picture says he has this osteophyte and he has this fracture which needs to be shocked hard. But your patient is going to die and scream if you actually shock hard on the first visit. So many times we have to pull back our indications and shock the patient and treat the patient. Informed consent is important. It's a painful condition. You don't want the patient to say that, oh, the doctor didn't tell me what it was all about. Yeah. Dosing and energy levels. You would consider in your mind how many treatments, usually 1 to 3 if you're using a focal device, we would give every fortnightly. I had the opportunity to go to Utrecht University to see them grow cartilage on alginate crystals. So they do take some time to actually grow. The tissue proliferation doesn't like and give you a miraculous cartilage or muscle or bone. So it takes at least a week or two. So do give a week or two duration for them to have some response. So with that targeted approach, we'll go on with the next slides. We have a preclinical data from 2015 up to 2023 May. And we included all the patients 18 and above using this device, using the ISMST guidelines. So as usual, we would give 1,000 to 1,200 pulses, anything from 0.08 to 0.27. 0.27 is the highest energy level that one could achieve. 0.1 is usually the therapeutic dose that you try to achieve to actually do something. But if you are actually using the shockwave for tissue healing, cell tissue studies have shown that you would need to use a low energy level like 0.08 to 0.12, maximum 0.13. If you give anything more than 0.16, you will have more cell apoptosis. So these are examples of what we will do. We'll talk more about this because we will go through 8 slides talking about the new indications where we will see this. So we collect data on diagnosis, symptom duration, region, tissue type, treatment number, applicator type, energy flux density, number of pulses, total energy, pre and post pain change, patient perceived outcome score, which is a 5-point Likert scale, and the post-treatment adverse events. So these are the main things that we decided were the simplest things which are reproducible, things that we can easily note down every time after the treatment. And patient perceived receive another treatment if symptoms persisted after the follow-up. And the follow-up is anything from 2 weeks to 1 month. So do note that we are fairly strict about the definition. So any injury is within the first year is considered the same injury. Anything which is occurring again after 1 year, we consider it as a new injury. So the demographics, we did treat 2,311 times. Most of the patients were male and non-athletes, and these were done in 1,454 individual patients. And non-athletes were usually older and have a higher BMI than the athletes. And obviously this may change how we will actually treat the patient. And athletes are mostly from football, volleyball, athletics, handball, and basketball. So this is also different if you see a different population in your clinic. So do note that this is not because footballers need more shockwave. No, this is because of the population that we see. And if you look at the tissue type, the most common are the tendon, followed by fascia, joint, bone, and muscle. In the region, the most common are the foot, ankle, knee, shoulder, and elbow. Although we do treat other regions also, these are the most common which occurs in our clinic. Now, how many treatments do we actually use? per patient. So over here, you can see most of the patients will use up to 2 treatments. That's 86.6%. Okay. So unfortunately, we do note that for athletes, there are more athletes who actually use more than 2 treatments compared to non-athletes. Okay. This is because of the fact that their techno activity score is much higher, anything from 6 to 10, where our non-athletes only have 1, 2, maximum 3 or 4 in activity score. So their requirements are much lower. So many of our athletes who are treated actually go back to play, and they continue to play. Yeah. Though the big difference is they don't use preventive use of NSAIDs as much as before. They don't go for so many corticosteroid injections, and they are able to play perhaps full matches rather than just playing for 10 minutes or 15 minutes. So that's a big difference for your athletes. Now, if you look at the region, how it affects various regions, we do know that it actually works in all the regions, perhaps less effective in the thigh and the leg, but most of the patients get anything from minus 2.4 or minus 2.8 pain reduction, which is not too bad. And these are the immediate pain relief. If you look at the different tissue types, it works in all different tissue types. Perhaps much better in fascia, joint, tendon, and muscle, but or should I say it's almost the same all over. And these are the data from 2015 to May 2023. And you find that the adverse events, which are most common in elbow, followed by shoulder, ankle, knee, and foot. We did not include finger because we only had very few cases. Yeah, I leave them all to Dr. Elizabeth, and she does a great job. What I would like to draw your attention to is it's a painful condition. Okay, so some of the patients get dizziness. You really don't want to have a patient get dizziness in your clinic. You will have to call a code blue because you've got to put them in a recovery position, offer them some drinks. You will have to change the clinic. So over here, do note that if your patients are being treated with high energy level, if they're fasting, if they miss their meal, and if they always have problems with injections or any procedures, perhaps prepare them a little bit more, tell them, come back another day. They always insist, I'm good. And the last Ramadan, we had a couple of them who insisted that they were good, but they were not good enough. So as a result, we only treated them halfway, and we had to call them back again. Yeah, so that's not very good, even if you are not doing a study. So from here, the rest are not so important, although giving more pain is not good. So do note that some patients do have more pain when you treat them, and some people have a little bit of a petechiae or redness, but no big hematoma. But another issue that I would like to draw your attention to, swelling. If any of your patients have double anticoagulation, do tell them 5 days you need to stop one of the medication. You can keep aspirin, but you cannot keep both of them. Because I had one patient who insisted, 2 days. The surgeon says, no problem, you will have no problem with shockwave. I give him a lower energy level, and he had swelling in his fat pad. So it took a week to 2 weeks to actually get it resolved. So I stay away from people who have double anticoagulation. So do note, it is a problematic thing. But all said, 27 out of 2,311. That's a good result. That's very few of them having adverse events immediately post-treatment. So do note that the most common areas are the tendons, joints, bones, fascia, and ligaments. And we noted that non-athletes seem to have more adverse events, and this could be because we had to use a higher energy level for their conditions. So may not be because you are just a bad group. No, it's because of the use of higher energy level in some of them. And obviously, we did note that the use of higher energy level, it was in 14 patients, more than half, and those who never had a previous treatment. So those who are naive, first-timers tend to have this problem. Once they felt that, oh, maybe it works, let's have more of it. So they'll feel less dizziness. So over here, we have the top 25 indications in shockwave in Aspetar. This using the number of treatments. I can find that the ones in green are the common indications. And the ones which are not so common are the ones in yellow, namely the plantar fasciopathy with partial tear, ankle impingement, whether it's soft or bony impingement. And the other thing is the knee focal cartilage defects, knee patellofemoral joint pain. A lot of them will have some Hoffa fat pad or even plica. And acromioclavicular joint OA, plantar fascia fibromatosis, and epicondylopathy with partial tear, metatarsalgia or stress reaction. These are the ones with a bone stress injury of grade 1 or 2 using a Fredrickson's criteria, and Achilles tendon with partial tear, quadriceps tendinopathy, ITB syndrome, rotator cuff tendinopathy, and knee osteoarthritis. So for those people with partial tears, we don't take people with more than 50% tears. We take those with less than 50% tears. Because we don't, unfortunately, we don't believe in miracles. We believe in pure science, and we don't believe in putting the patients to additional risk. So if you look at the first row, you do note that we have the patient perceived outcome scores, then the total, and then the next one, B plus MB, are the responders. Okay, those who indicated they are better and much better immediately after treatment, and the non-responders are those which are W and UC or worse or unchanged, which is the last row. Okay, so we will carry on. And from this, we actually noticed that most treated indications resulted in better and much better outcome. A lot of them are above 90. But these are immediately post-treatment. That's why we need randomized controlled trials after this. There are few indications regarding more than 10% of immediate failure to response were Achilles tendon, mid-substance tendinopathy, rotator cuff tendinopathy, plantar fibromatosis, lateral epicondylopathy. Okay, it doesn't mean it doesn't work. It's just that it's a little bit more difficult to treat. So sometimes you need to provide another session, or you just have to fine-tune the energy levels given. Now, when we talk about new indications, we actually compare with the common indications. So if you cannot compare with something, then how would you know that it actually works? So we look at three things: the number of treatments needed for each patient, the effect size, the pain change, and the patient perceived outcome score immediately after the treatment, and a targeted approach where we would actually have specific concerns of treatment parameters and precautionary measures. So with this, all of you here, if you have a device with a little bit of practice, can actually start treating some of these patients. When you look at plantar fascia, there are at least 3 different indications. The one which is not shaded is common plantar fasciopathy. The one which is new is plantar fasciopathy with partial tear and plantar fibromatosis. And as you can see here, all of them do respond with 1 to 2 treatments, and possibly a plantar fasciopathy may need more treatments. And if you note here, the mean pain change quite good, even for those with a plantar fascial tear, but there is a tapered response for plantar fibromatosis. Okay, it's difficult to treat. It's very painful. Patients often have a lot of problems. Please don't massage the plantar fibromatosis. I tend to go with exercises only. They respond very well. Focus shockwave with low energy level. Over here, you can see over here that if you give 0.08 to 0.12, it actually works very well. And as you can see over here, for the patient response, 90% of them actually do quite well. So they do respond. Okay, so these are the summary of all those whom we have treated. Okay, obviously there are those who still insist they have a lot of pain, but when they come back for follow-up, they say, hey, I actually felt better a couple of days after treatment. So some people don't respond immediately, yeah, but most do. So always consider ultrasound scan in a skilled MSK radiologist's hands to actually find out what is actually there. We do see a lot of studies where they say it's a clinical diagnosis. Yes, it's a clinical diagnosis, but if you want shockwave, if you want best treatment, please do an ultrasound scan. Yeah, MRI is very, very good, but ultrasound scan is more than enough. Achilles tendon, easily 4 indications here. The common ones are the first 3, Achilles insertional tendinopathy, calcific tendinopathy, missed substance tendinopathy. And the new ones are tendinopathy with partial tear. Do note that they all respond very well with anything from minus 2.2 to minus 2.7 pain change, but those with missed substance tendinopathy, it's a pain. Yeah, they don't respond as well, but do consider using a different treatment parameter, as you can see later on. But all of them respond very well except missed substance tendinopathy. 80% is still not bad. Yeah, still not bad. So if you have tendinopathy, use anything from low to medium. But I would go with medium if you can, if the patient can tolerate. Calcific tendinopathy, you need to shock them hard. Go all the way, provided they are not in the acute phase. Okay? If you're trying to break calcification or break some antisopathy, you need to shock hard. If they have tendinopathy with partial tear, tendinosis, where you want to optimize the tissue regeneration potential, and tendinitis, where it's acute, where you want to reduce some of the inflammation, you do use a low energy level. Okay? There's no two thoughts about it. If you are very aggressive, the patient will have a flare up. The patient won't be thanking you. Okay. If you make the patient very well, patient will go and run and jump and snap his Achilles tendon because it's not ready. So we do always encourage to continue the rehab. So there's nothing like magic. Rehab, physiotherapy is the primary treatment for most conditions. Rotator cuff tendon, should I say, unfortunately we only have 2 indications here. There's supposed to be a third one, but there are only 9 treatments, so we only kept 2 over here. So they do respond quite well. Obviously for rotator cuff tendinopathy without calcification is a tapered response. And if you look at the patient perceived outcome score, they are pretty good, almost 90 or above, but better with calcific tendinopathy. So it's something that you can go for, even as a first line. There's pain reduction and patient perceived outcome improvement for calcific tendinopathy, and this is much better. If you look at lateral epicondylopathy or your tennis elbows, you compare with those with a partial tear, they do respond similarly, and this is strange. Again, maybe all the patients are trying to make me happy and say that they're better or they are avoiding the shockwave because of the pain. No. You do know that they almost have the same response, if not better, with those with a partial tear. You need to have a proper energy level. Those with a partial tear, you use a lower energy level, and you start with home-based exercises. They all do well. Okay, even without sending them to rehab. Obviously, if they have rehab, it's much better. So it's because lateral epicondyle is a small tendon. It's very sensitive. You press on your own elbows right now, you'll find that if you press hard enough, all of you will hurt. So if you shock them, they hurt quite a lot. And if you have a partial tear, they definitely hurt a lot. So do be careful to provide a lower energy level. Knee and AC joint osteoarthritis, the osteoarthritis. Okay, they all do very well with 1 or 2 treatments, and seemingly better with knee osteoarthritis with minus 3.3 compared to AC joint OA. And obviously we have a few cases, so we can't say that everybody does well. But in our athletes, when we shocked them, everybody went back to play. Yeah. So this is something that you do see that patients who are provided shockwave therapy do respond almost immediately. Especially over here, you know that treatment of knee OA is painful. So you should reserve for those who has started a physio or has done some injection therapy but failed, and those who are willing to take the pain. Yeah. So at least 8 out of 10 pain score is there. The other thing is the knee is a big joint. The bone seems to absorb a lot of energy. So you will need to give more shocks, so 1,400 to 1,500 shocks to each articulation. You will treat the medial tibiofemoral articulation one day and a lateral tibiofemoral articulation another day, and maybe the patellofemoral another day, and otherwise you will have to have 2 sessions because we have 20-minute slots. So again, the treatment parameters are you use the high energy level. You need to give fewer shocks with AC joint, but roughly around 1,000 shocks. But for the knee OA, you need to give more. Knee focal cartilage defects is something new. We actually look at this data during the surgical skills course by ICRS, and we actually found that most of the patients referred only needed slightly more than one treatment with a pain reduction of -2.9, and these were reserved for those with full cartilage lesions, especially those with bone edema. So we do believe that if you actually shock the subchondral bone, then the cartilage has a better chance of surviving. We did do serial MRIs in a few patients. We did find that the bone recovers, the bone edema goes away. Unfortunately, the cartilage defect is still there, and sometimes you have some delamination. But the patient is able to play 2 to 3 years down the road and is jumping around like never before. And we are thankful because they continue to send players. These are from handball and volleyball and basketball. So as you can see here, they all respond. And it's the same thing. Keep this for those who are bad. Metatarsalgia and stress reaction. Again, they only need slightly more than one treatment, have a good pain reduction, and also a huge number of them actually respond pretty well. And you will use a higher energy level sometimes, but because some of them are quite painful, so you will probably go from medium to high energy levels. For ankle impingement, patellofemoral pain, and ITB syndrome, the first one is of a different pathology. There's anterior and posterior. There's soft tissue impingement and bony impingement. So they may be different. Those with patellofemoral joint pain are also different. There are many mechanisms why one would have. They could be due to the patellar malalignment, could be due to muscle imbalance, maybe related with the IT band syndrome. So they are difficult and maybe related with a Hoffa fat pad or plica. So there's a whole range of things which can be there, but they all respond quite well. Iliotibial band syndrome respond very well. Again, it depends on where the location of pain is, whether it's in the thigh or whether it's in the knee. And the acuteness and the level of pain will be different also. But they all respond quite well. So you have to have a targeted approach. You have to know what you're treating. If it is a soft tissue impingement, you will use a lower energy level. If it's a bony impingement, you can use a higher energy level. And for patellofemoral pain, it's a myofascial pain most of the time. They do really well with low to medium energy levels. So you don't really need to shock until their eyeballs drop off. So all 3 conditions respond pretty well to focal shockwave. So I've mentioned the rest earlier on. So there are limitations of this chart review of this work that we have done over here. It is not research, it's the day-to-day work that we are doing. So don't take this as biblical truth. So we only have immediate post-treatment change in pain and patient perceived outcome. There is no control group, there's no randomization, and do note that rehab, home-based exercises, and Crossover injection therapy or surgery sometimes may not be documented. And fractures are not included because you need to look at the radiological findings, which you will not find similar references or comparison with the pain score or patient perceived outcome. So, just as a reminder, these are the new indications, and these are from those who are most common down to those who are less common from the top 25. Again, plantar fasciopathy with partial tear, ankle impingement, knee focal cartilage defect, patellar femoral pain, AC joint OA, plantar fibromatosis, lateral epicondylopathie with partial tear, metatarsalgia or stress reaction, Achilles tendinopathy with partial tear, IT band syndrome, and knee OA. Take-home message: sports injuries and musculoskeletal pain syndrome respond well immediately post-treatment with targeted approach of focal shockwave treatment in both athletes and non-athletes. Most indications for focal shockwave require 2 treatments only, although a greater proportion of athletes may require more than 2 compared to non-athletes. Focal shockwave is safe if used appropriately. More well-designed RCTs are required, and I do encourage all of you, if you know anyone who wants to do a PhD or who wants to assist to evaluate prospectively, do come to me. We will have a look at various options, how we can actually do this together.